At this time, I'd like to introduce our presenters, Dr. Bob Conder and Dr. Alanna Conder, K4RLC and K4AAC, and I'm going to turn the microphone over to them.
Okay, thank you, Jay. Can you hear me okay? Okay, thank you very much. I'm going to start at the beginning and do a little overview and then turn it over to my better half. The topic today is catastrophic sports injuries. This is a spinoff of a previous net which focused more on concussions. We'll get to concussions, but we want to cover the whole gamut of catastrophic sports injuries that can occur at any level of play. A little background. My better half, Dr. Alanna Conder, was assistant professor of psychiatry in the Department of Pediatrics at the Medical College of Virginia in Richmond. And that's where I was in the Department of Physical Medicine and Rehabilitation, working primarily with traumatic brain injury and spinal cord injury. That's way back over 30 years ago. When I first started working with serious sports injuries. Both of us have been members of the Catastrophic Sports Injury Prevention Task Force, founded by the Injury and Violence Prevention branch of the North Carolina Department of Health and Human Services. I was on phase one, the initial data gathering phase, which is finished, and Dr. Alanna is on phase two with implementation, and her specialty is K through 12, since she's been a pediatric neuropsychologist working with the school system here, Wake County, the largest school system in the state of North Carolina. We both worked with the National Hockey League concussion program, primarily. I was at the beginning, and our team assignment was the Carolina Hurricanes. Some people think, oh, you're working with the Canes, which you were, but it was, overall was a league program, so that we answered to the league and not to the team, which kept some of the pressures and dual relationships and responsibilities out. And in doing that, also saw players from any of the NHL team. And then was a member of the North Carolina Sports Safety Task Force, which wrote the draft, which became legislation for sports safety and concussion management for all the public schools in the state of North Carolina. And I was very privileged on that group to be with Dr. Josh Bloom, the sports medicine physician for the Carolina Hurricanes, who actually had been a quarterback at Dartmouth, Ivy League football, and Dr. Kevin Guskowitz. So way back when he was not as well known, he was just chair of exercise and sports science at the University of North Carolina, Chapel Hill. Go Heels. Hey, Jack, there's another Tar Heel on here. Great to hear that. And then Kevin sort of became chancellor of UNC Chapel Hill, and then he decided to leave us for the Spartans, and now he is president of Michigan State University. So a really good work group of sports medicine, athletic training, exercise science, and neuropsychology. And we'll, whoops. Okay, first glitch here.
This is AA4. I fell off the mic temporarily. So we're running a Zoom simulcast, guys. So even though we have slides that we're using as a prompt for the presentation, if you're an amateur radio operator on 20 meters and you'd like to see the slides, realize that we will have the video available afterwards on our YouTube channel. And this is just a prompt. Our presentation is 20-meter based. It's net based. And we'll be moving on here momentarily. So the Grand Rounds Linear Net has been in existence for many, many years on this frequency. And our prior net control has recently passed away. And he was 99 years old. So it was good for his health to participate here. And we'll talk more about that as well. And I'm going to turn the presentation back to Dr. Bob.
Thank you, Dr. J. And sorry, I had a little keyboard glitch here. Hopefully you can see a slide with 3 teams right now. Okay, yeah. These are teams we've worked with and learned from. Top left, Carolina Hurricanes, when they won the Stanley Cup, and that's the current coach, Rod Brindamore. Bottom left, North Carolina State football. But our favorite really is over in the right, and the white team. And that was our son, and how we got really involved when our son decided to switch from soccer to football. And he played 4 years of varsity football, a couple of years of JV, and at one point was a four-sport athlete. And this is an away game, so the idea of Friday night football in North Carolina, you drive your pickup truck right up to the sidelines and have a good time. And Bobby's the little guy right in the middle of the scrum there as a tackle. He wasn't big enough to play college ball. He went on to Chapel Hill, and all I'm going to say is he never got injured in high school at St. David's, but he got a few injuries playing fraternity sports, and we won't say any more about that. The athletes, some of these are just some of the most incredible people you've ever known. With the Hurricanes, some of the most elite athletes who actually were on the U.S. Olympic hockey team, and super nice people, and just in terms of physiology and conditioning, some of the most well, let's put it this way. They didn't do aerobic metabolism. They did anaerobic metabolism. That's why you've got short shifts on that. But just super, super nice people. In general, we sort of looked at this in the past. These are the top 10 sports injuries in the general population. And a lot of these musculoskeletal injuries, number 8, concussion, and Dr. Alanna is going to spend a lot of time at the end talking about concussions and management of pediatric concussions. These are the most dangerous sports and all. Some of these you won't see in K through 12 or the college level, like base jumping. Some schools do have equestrian sports, which can be very dangerous. Usually rock climbing is a club sport and not a varsity sport. So let's sort of get into youth sports here, looking at the sports with the highest concussion rates. Boys tackle football is the highest, and in terms of position, when we look at specific positions or responsibilities, the tackles, 63% of concussions come from tackling in high school football. If you ever tackled, you know it's sort of a neat experience. Run down the field real hard, grab a guy, throw him down on the field, and flop on top of him, and it's legal, but you want to do it safely. Then boys wrestling, and it's the takedowns, a little similar to tackling. And then girls basketball, 51% of the concussions come from collisions. Basketball is definitely a contact sport. If you look up here, top right, you can see this logo, CDC Heads Up, the Safe Brain, Stronger Future. This is a wonderful program that the Center for Disease Control and Public Safety started decades ago. And you can just Google it, CDC Heads Up. And they do wonderful data collection, because we really need data to know what's going on to plan safely for prevention in sports. And also training. There's training for coaches, parents, and for officials. Some of the smaller schools and high schools, the people who are officials or volunteers and can't go through formal training in terms of concussion management. But if you get a chance, go to that website. It's a wonderful use of tax dollars and helps very much with safety. And that's sort of what we want to get at with this. And it comes up to this slide here. The National Center for Catastrophic Sport Injury Research is at the University of North Carolina and has been there since 1965, originally tracking football-related fatalities, then non-fatal football injuries, then non-fatal serious sport injuries. Fred Mueller led the program for 30 years, wonderfully nice person who also is a lacrosse coach, recently has retired, and Bob Conder, a neurosurgeon who's famous with the Boston University CTE NFL autopsy studies, is the medical director. This data collection, we're looking at really good empirical data collections, led to rule changes in sports, which has led to safer sport participation, and that's what we really want. Our bias is that sports are good for kids. It's wonderful to learn team sports in terms of how to get along with other people, how to play roles, how to give direction, and how to not just learn to win, but how to learn how to graciously lose. That's very important in life to do that. And also,
we just break for a second, Bob.
Yeah.
This is net control, Alpha Alpha 4 Foxtrot Lima. This is Whiskey Bravo 5 Delta with K4RLC for identification purpose. This is Grand Rounds on the Internet. We meet weekly on this frequency and discuss topics related to the health. We have a passion for topics related to health, and we share our passion for amateur radio and health-related topics with each other and with the amateur community in general. That being said, we would like to encourage you. This is not a presentation lecture. This is an interactive net discussion. And do we have anybody like to check in? You don't have to be a member here, because we do want to know who's here when it comes time for us to ask questions, so we can properly do this as net control. Make your call to Whiskey Bravo 5 Delta. Any additional check-ins? Make your call to Whiskey Bravo 5 Delta. I do have AE4BX Mary checked in from South Carolina. We have WJ8B also checked in from Ohio, and W0FFC also checked in. We have 3 additional check-ins. Thank you for joining us. If you're coming in through Zoom, make sure to mute your mic. So we are doing a simulcast on Zoom as well, and we make the recordings of these sessions available to all amateurs and to their families and friends on our YouTube channel, and that should be up tonight, which is Healthcare Hams channel. If you look on YouTube, throughout the discussions today, for those of you on 20 meters. We're describing what's on the slides and giving you the opportunity to search for information on the internet, since you don't have the availability to see the ones that we're using here to prompt the discussion. We do have the advantage of having slides running for us that are guiding the presentation, so that we can prompt and coordinate what's being said. So please look for that later today on the Healthcare Hams channel. You can always email me for any links as well to recorded information at my personal call of Alpha 4 Foxtrot Lima. So thank you very much for everybody joining us today, and for all amateurs allowing us the use of the frequency. That being said, I'm going to turn the mic back over to Dr. Bob Conder, K4RLC.
Thank you, Jay. There's a lot of stuff here. Basically, NCCSIR focuses on youth, high school, and collegiate levels of play. And again, the overall goal is the prevention, evaluation, and management, rehabilitation of catastrophic sports-related injuries, with a lot of emphasis on gathering good data for prevention. Now, let's define what a catastrophic sport injury is. It's one which has a fatality, unfortunately, and tragically a fatality. Injuries that result in a permanent partial disability, and serious injuries that result in a functional disability with full recovery. And these are 3 categories of what are considered catastrophic sports injuries, things you may not think about. Environmental conditions like lightning strikes can be fatal. Exertional heat stroke certainly can be fatal, but there are training programs for that. For example, the Paris Olympics was really hot, and there was a specific training program for accommodation to heat. And on the left, injuries such as traumatic brain injury, spinal cord injury, commotion cordis, and on the right, illnesses such as sudden cardiac arrest, hyponatremia, and rhabdomyolysis from dehydration. But a lot of these, the idea, and Dr. Alanna can talk more about developing an action plan. This is a wonderful infographic from NCCSIR, and it sums all of the 2023 football fatalities. There's a 46-page report that goes with this. All this is free to the public, and you go to the website and look at that. But there were 3 deaths due to traumatic brain injuries, 16 unfortunate fatalities among football players at all levels, and that 10 of those were exertional medical. One of the things I want to do is sort of depathologize concussions. We've spent most of our career working with concussions, and it's not that the only thing that happens, and is not as it's not the same thing as a traumatic brain injury or a CTE. This is an infographic of non-fatal injuries. If you look at the trend over years, you can see 2020, there were few. That's because most of the programs were shut down because of COVID. And if you go to the middle there, you can see most of the injuries were C-spine, the cervical spine, extremely vulnerable in tackling T-bone, horse collar tackles, and things like that. 88% occurred during the game. The old thought was most of this was during practice, but now it's game stuff, and about 60% during high school athletes. Then another wonderful infographic. We could spend a whole hour going through this one, but if you look at the middle top, the pie chart again, football 42%, and in terms of injury type, cardiac 46%. And that most of this is during a game, and most of this is in high school. And there's reasons for that Dr. Alanna will get into. This is just the idea of sort of the sports pyramid, that we've got maybe 40 million kids, youth, recreational, who start playing, and then as you go up the pyramid and you get to JV, varsity, collegiate, there are fewer players because they're weeded out. A lot of players have the idea, high school, I'm going to make it to a college team, and now especially in the college, I'm going to make it to the pros, to the NFL, and there may be 1% or more, 1 or 2% get from college to the NFL. Okay, now I'm going to turn this over to my better half, Dr. Alanna Conder, who's going to talk about the CSI phases and implementation.
If we could, before we turn it over to Alanna, this is Net Control, Whiskey Bravo 5 Delta. Are there any questions of Bob? I'd like to go ahead and take a list. I know we were talking about infographics. My first question before I turn it out for general questions and make the list. Bob, we're talking about statistics that are from North Carolina's, and could you describe what CSIR so people could look for that on the internet? Could you talk out the website link for those on 20 meters, please?
Yeah, no, this is national. This is the National Center for Catastrophic Sports Injury Research. I think it's nccSIR.unc.edu. I should have the website for that. This is national. It's a surveillance program. Some of this is, there's not a mandate to report, but it's very easy to report. If you don't have to be injured, or the parent of someone who's injured, you can file a report. They also look at the media, because anytime there's injury, there's a lot going on. But no, this is the entire nation, all the U.S., and this is youth, really K through 12 and college sports. I reached out to some friends with some of the other pro leagues, we won't say, but they have this data, but it's not the kind of stuff that is publicly reported for a number of reasons. We won't go there, but let's just say that the NFL and the NHL has the data, but it's proprietary.
Thank you, K4RLC, AA4 Alpha the Mike. Thank you for answering my question. Are there other questions here on 20 meters? People that would like to ask questions, make your call, and I'll make a list on 20 meters here. Make your call to Whiskey Bravo 5 Delta.
For FL2, I said real quick. I'm looking at this from 2 points of view. Obviously, it's expensive, but as some of you know, but not all, when you I became an EMT. In New Zealand, we have a little bit different sports ethic, I guess. So lacrosse is a major sport here, almost at some schools bigger than football. And as an EMT responding to those injuries, I wonder if there's a difference. So when Alanna, as I talked about it, I'm going to be paying particular attention to both focuses. Hopefully that makes sense. I'll leave it there, Jay. Thank you. KD4IZ.
Okay, thank you, KD4IZ. AA4FL at the mic, Whiskey Bravo 5 Delta for the grand rounds in the air. Nat, we appreciate that that comment from Jack 84IZ coming in through 20 meters. Thank you very much, Jack. And we're going to turn it over to Alanna, and she can address that momentarily. K4AAC is going to be our next presenter. And again, realize that we are doing a simulcast on Zoom. We are going to make a YouTube video that will be on the Healthcare Hams channel. But this is an interactive discussion and forum, and everybody will have the opportunity to give their input and have questions as well. So at this time, I'm going to turn it over to K4 AAC, Dr. Alanna Conder. Go ahead, Alanna.
Thanks, Jay. First, can you hear me?
Everything's good.
Good. Second, I could not hear actually his comment. I could hear, but I couldn't discern what the intelligibility of the words was. I just could hear the volume. So if it's something that I need to answer, then could you put it down into like one sentence worth of question or comment? I couldn't hear it.
The question was, lacrosse is a very big sport in Virginia. He was hoping you would comment on lacrosse as well as football and other sports.
Absolutely. There will be some, and in one of the former infographic slides that Bob had shown in terms of how many sports, Bob, can you just go back really fast to the one that had the diagram of the 10?
Well, this one, sure, in the middle, lacrosse is 5% of the injuries. If you see the pie chart in the middle there.
The catastrophic sport, yeah, but of the 92. But could you just still go back for just a second, really fast?
Well, I'm stuck again.
All right, never mind, forget that. Let's just go on. Yeah, I mean, girls lacrosse, in terms of, I think was fairly high on the list. They were actually in order of the prevalence of the injuries. And if we go back later, maybe I can have a chance to look at it, that, it does come in higher for by gender also. But Bob, can you get it to the first screen that I'm supposed to cover?
That's what I said when we changed the view, and I lost control of the screen here.
What view did you change? Oh, we'll go back and change it again for a second.
Well,
even if you back into presentation.
Yeah, I can't get it.
Before I felt the mic, we're just pausing for a minute. Technical difficulties. Again, we're doing a Zoom simulcast here.
Okay, well,
there's a 20 meter net here. So for ID purposes, the medical imagery will count to grand rounds of the net, and we're talking about catastrophic injuries today, and we have K4AAC, Dr. Alanna Conder at the microphone, and she'll be speaking about her subject matter here, so we can have an interactive discussion. Go ahead, Alanna.
All right. Well, I'm going to just try to talk without the PowerPoint and give him good luck to find it, because we will need that for me. But so basically what happened is, yeah, there we go. That would be fine with me. In the phase one with the part of, they looked at all of these, all the different statistics on different injuries, what level of them were of the catastrophic injuries, what sports accounted for them, what factors accounted for difficulty, and made those infographics at the end of that whole year of that process. They tried to put a lot of information in about 6 different reports that are lengthy into about 6 slides of infographics. The phase 2 piece where I came in was we had to plan how to implement the recommendations. So what they came out with were looking at all of the evidence-based practices that had good support for how you would handle various aspects of what they had discovered by looking at their data on what would create a potential for a catastrophic injury and what factors would need to be controlled in order to help with the prevention. And usually the prevention, as we'll see in a couple slides later, has to do with better education, better identification of phases where you could intervene to keep the outcome from being less catastrophic. And then they looked at the feasibility as well as the high priority of the different pieces of this data set, and created some evidence-based practices based strategies of what they wanted as their goals. So when they started phase 2, the whole idea was, how are you going to implement the goals, and how are you going to create structures that are going to allow you to do that? And not just in terms of the task force that I was working on had it divided up as community and school. And the school folks, which I was on their panel, were a lot better off, because there are right now legislative agendas that are requiring schools to have programs in place at this point in time. So the school-based people were already at an advantage, because since it was law that you have emergency action plans and that you have guidelines, they already have done that. The community-based folks are looking at all the community-based sports that includes the earlier levels of education, when you have youth sports as well as just community rec leagues. And sometimes they don't have as much infrastructure and there's a lot more variability. So they had to take it from that point. The whole point, I would say, of this CSI data set being important is that it talks about what is going to go into prevention. And obviously knowing how many of the injuries that were catastrophic were of what type is not as important as knowing, now that we have data on all of that injury statistics, what would we do to prevent people who are trying to play sport for reasons of health and enjoyment at all different levels from experiencing a catastrophic injury. So next slide, Bob. The whole point for the task group was to work on different aspects of prevention, which we'll talk about in more detail, but they talk about the 5 E's of prevention. The ones that I want to just, those being education, equipment, emergency responses, looking at environmental factors, and engagement. Without going into this slide in detail, education has a lot to do with making sure that everyone understands what are the signs and symptoms of various types of these injuries and illnesses, and how would you address them, and how do you manage them appropriately, not going on old, ways, but more evidence-based practices at this point in time. The equipment, we're going to look at that, and that has to do with a lot of making sure that the various sports have properly fitted equipment, access to that equipment, consistently worn and worn appropriately, and emergency equipment has to be available. And we'll talk about that, AEDs, and having people on site who know how to do CPR when necessary, emergency responses. The environment has to do more with, now that we understand that what the effects are of exertional injuries, heat, need for heat acclimatization, and what can happen even though it's not high frequency, if there is a lightning strike, there have to be policies that address environmental factors and conditions, and how you monitor those and how you have plans in place to address them. Next slide. Bob, that. So one of the first stages in trying to help prevent is to have federal legislation that has included various different acts over time, but the Youth Sport Concussion Act, interestingly enough about this one, it started in 2013. It got pretty good support really right away, but a bill has to make it at the federal level through all these different stages. And it took until 16 before it could pass both houses, and with support from both houses, as well as bipartisan support. So it takes a long time for a federal bill to make it through. You have so many pieces of that process that have to go through. One of the ways they got it to move quicker, though, I thought was interesting, is that bill not only talks about how you would respond to a concussion, but it also talked about the dangers of false advertising claims for sports equipment, because there were, when concussion became the thing, there were lots of sports equipment manufacturers that were making lots of claims that by wearing this band or, this halo, you could eliminate all sports concussions. And it just was false advertising. So by having it go through the Committee on Commerce, Science, and Transportation, they linked in the false advertising piece, which then gave it another area of sort of like teeth to it, and it made it through those committees, and not only ended up having the youth sports guidelines be part of the legislation, but also enforcement powers for manufacturers trying to sell equipment that might be making false and misleading claims, because they could be sued. Next, the state concussion is probably more important than federal, really, because every state gets to decide how they're going to handle things. Thankfully, 2014, all 50 states had finally signed on board. That took a long time, plus DC. They have statutes in place. What's covered in them is very different. But at this point, if we look at it now, as of 2017, 100% of them do have concussion education requirements in terms of emergency action plans and education. Education includes education to coaches, education to athletic directors, educations, of the athletic trainers that are going to be involved for the places that do have an athletic trainer on board. Every party, education of parents and students. 100% of them have removal from play if they have actual symptoms of a concussion. But at that point in 2017, 48 out of the 50 had not allowed to continue playing on that day. So some of the things that you're familiar with watching professional as well as non-professional and collegiate sports, you can see some of these issues of when do you pull a player, how soon can they get back, what do they have to do? Next slide. Is a specific concussion legislation bill that we're pretty proud of. It's here in North Carolina. If you notice the date down here, it says it was signed into law in June of 2011, which means well before that 2016 federal bill, as well as well before the point that most states had a lot of these in play. Going back to what Bob said earlier about his opportunity to work on the task force that included Dr. Bloom from sports medicine, as well as he may want to actually take some credit and talk about this, but as well as looking at Kevin Guskowitz's role, Bob was a third party in helping to craft the legislation that went into effect here in North Carolina. So sports neuropsychology was the third component after exercise and sports science and sports medicine. And it has three main features: education to all the parties that I just mentioned, return to play regulations so that you can ensure safety and health. And this was for all the high schools and middle schools that it was being required, and to have an emergency action plan in place. Bob, did you want to say anything else about the Gefeller Law?
Before we go to Bob, can we just go ahead and break for ID here for a second? This is Whiskey Bravo 5 Delta, the Medical Amateur Radio Counselor, also known as Healthcare Hams, Grand Rounds on Internet. We meet every week at this time, and we're very fortunate to have two presenters today discussing our net topic, Dr. Alanna Conder, K4AAC, and Dr. Bob Conder, K4RLC. And we very much appreciate the depth that they're going to and the information they're offering you to follow up at home on the internet. So for additional, and they're doing a wonderful job. They're prompting off of PowerPoint slides, and they're verbally telling everybody on 20 meters how to find this information to further investigate it. And that's pretty much the way we do all Medical Amateur Radio Council events, even in our publications. We use hypertext because we want everyone to get the basics and then pique your interest and let you follow up and follow your own path. Many of the amateurs here that are listening today, the general amateur community, and thank you for allowing us the use of the frequencies you do every week. You have grandchildren that play sports at the different levels of K through 12, and you might particularly have some at further levels of your own interests. And in the past, we have talked about other kinds of sport injuries, not just brain-related, concussion-related injuries, but we've also talked about orthopedic injuries. And our two presenters here, the Conders, have volunteered to focus on this one particular area of discussion. And the Grand Rounds on the Internet is formulated that way. When you talk about a topic, one great topic actually brings up many more questions. And before we move on with more comments from doctors Bob and Alanna, on 20 meters here, do we have any questions or input? Anybody like to make a comment? Let's pause one here and give a chance for our forum interactive discussion portion of the net. I'll make a list of anybody with discussable items. Make your call to Whiskey Bravo 5 Delta.
Whiskey Bravo 9 Echo Delta.
I have Whiskey Bravo 9 Echo Delta Papa. Any further? Okay, Harry, WB9EDP, go ahead and ask your questions. And we may not be able to hear it well on this side. I may have to paraphrase it. So keep it short. I'll paraphrase it to the presenters. Go ahead.
Sure, I get to that point pretty much. We deal with the Schwab Rehab Center, but that is what we say post catastrophic type injuries that we send out to rehab. It's the soft science part of medicine. The area that I think most of the members would be very interested in is what I've done in a lot of other guys that come to emergency medicine or medicated trauma surgery. Is the initial impact of keeping someone alive so that we could get them well and then turfing them out, later down the course to be evaluated and in the rehabilitation area of as opposed to statistics of that. As a medical provider, we're not in the course of talking to the universities or schools of telling them who, what, where, when, or why. And to the EMTs and paramedics, their job is assessing and getting someone's package to send to me and talking on communication. This what's going on. I think that's really important. So this is when we start seeing a discharge and long-term rehabilitation over time.
Yes, I'll copy that here, Harry. Harry is mentioning that on the emergency medical side or the trauma response side, and I know Alanna and Bob had mentioned that EMTs and response on site was part of the education and preparedness. But at that point, when there is a trauma, then it moves on to the medical providers and the emergency medical responses that keep people alive till they can get there for treatment, which of course is a whole nother topic. And as we were talking about earlier, when we discuss a topic in the Medical Ambulance Radio Council here on 20 meters in the general ambulance community, we benefit from everybody's input because that's how we create our next programs. And we appreciate Harry's perspective, WB9 EDP. Thank you very much, Harry. Any other comments before we move on? Okay, Alanna, before you move on with Bob and where you were at in the discussion, did you want to address anything more about that transition from having the trauma on the field to the emergency and medical side of it? I mean, how is that handled locally in North Carolina as part of your task force? I'm going to turn the mic back over to K4AAC. This is Whiskey Bravo 5 Delta.
Thanks, Jerry. I do think we have some more slides that will talk to get to that point, but obviously you do have to have emergency medical. Part of the EAP process, emergency action plan, is that every one of the facilities is going to be able to be educated about what to be looking for and having the ability to respond quickly to any of these potentially catastrophic injuries. And when you're talking about having that happen at a professional level of sport, for example, they're going to have everything that is necessary, likely there available. But when you're talking about why do we need to have all of these rules and have these different structures in place, that's because when you're talking about youth sports all the way up through high school level, there's a lot of different variable levels of structure in there. And for us personally, at the especially the middle school through the high school levels, there's tons of devils in the details. And the first thing is that there has to be an emergency action plan that keeps the person alive. But that it doesn't mean that there should be ideally an AED at the minimum and CPR trained people available at every sport, every venue that takes place. And we'll look at some slides that say that, but every bit of that has to be mandated because we take for granted that when you're in an emergency room, when you're hurt, there's going to be everything you would need to do emergency management. And when you're talking about professional sports, because of liability and because of and a lot of these are also being televised, they do have all of that equipment and they do have everybody trained, but that you don't mandate that is required until you mandate it. So the legislative piece, all of these have laid in place ways to keep people safe so that first you save their life. Certainly first you save their life. But even when you're talking about some of the injuries that have happened very recently that have made the news about 13-year-olds who are football players who have sudden cardiac arrest right on site and whether they were saved or not. And in some cases lately, they have not been. there was unfortunately a number of cases that made the news recently. It's because they don't necessarily have either an AED on site or somebody who knows how to operate it correctly. They may or may not have somebody who is able to step in and do CPR. Maybe let's go on to a few more of the slides and we'll get to some of those pieces as well. But I agree, first you have to save the life.
Yeah,
but
let me,
make that happen.
just say the legislation, North Carolina, probably like Florida and every other state, we have really rich counties like Wake County, and we have really poor counties like Perquimans County where they don't have budgets for high school. Only a third of the high schools in North Carolina have an athletic trainer, and part of what athletic trainer does is basically EMT training. So the chain of command starts there on the field. You've got somebody with an AED, somebody knows how to do CPR, and then work your way up. And that, unfortunately, that had to be mandated. So I'll turn it back over to you.
Okay, and the whole idea, if you want to go ahead and advance the slide, a lot of the rule changes that have happened, and when we're talking about, both at the level of professional sports as well as the level of the high school sports, and particularly college, those rule changes that have been made are there designed to use the data that we now know about sports injury statistics and to try to adjust parameters that will make a catastrophic outcome less likely. If you remember, the catastrophic injury, the first one is the fatality. The second one is going to be having a very serious outcome that you have a permanent disability. And only the third one, which is concussions and head traumas, is going to be having an outcome that has immediate functional changes, but you do get to survive it and not have a permanent disability. So the rule changes to reduce head hits have happened in all of the sports. We just happened to pick soccer, hockey, and football. Soccer rules about heading, hockey rules about head hits and body checking, football rules about helmet to helmet and kickoff and punt returns. All of those are trying to decrease the amount of collision, because collision is what is the primary trigger for the catastrophic concussion, sport trauma, injury, and modifications to the protective gear. I think we just wanted to talk about helmets and mouth guards. Those are very well data-based at this point in time. Bob had wanted to make a comment about concussion caps.
Well, it's just it's interesting, the federal legislation looking at this. There's a lot of stuff out there that people are marketing, headbands for soccer, concussion caps also for the NFL. And a lot of this stuff, I guess, is done by well-meaning people, but there's not good research. And some of it, the concussion caps, actually increased the level of concussion and neck injuries in high school students. You really have to know the physiology there, that the neck muscles, especially girls playing soccer, is not like a mature woman or a boy. So the thing is, when you hear all this stuff, you want to have really good data and evidence-based stuff, because some of the stuff recommended actually can be harmful. That's my soapbox. Okay, go on.
Yep.
Let me break one. This is the Medical Amateur Radio Council of Grand Rounds on the Internet, and we have our speakers here with us, K4AAC and K4RLC. Dr. Alanna is K4AAC, and Bob is K4RLC. And we're speaking about catastrophic sports injuries. And we hope you're at the general amateur community is finding this very interesting. You may not have access to visuals in our Zoom simulcast, but you will later. We will publish this on Healthcare Ham's YouTube channel. You'll have a chance to review. And of course, everyone on the air here, this is a forum. This is an interactive discussion. This is not a lecture. This is amateur radio. This is 20 meters. So please bear with us here, and we appreciate the use of the frequency. And these are all amateur radio operators that are speaking here today, and we share a common passion of health-related topics as well as amateur radio, and the Grand Rounds on the Internet is our way of expressing as a group our interest in. I mean, after all, amateur radio operators care about health, and as we said earlier, you've got grandchildren that play sports. You have other family members that play sports. You're going to have children that play sports. So any topic that we discuss here we're looking forward to your input, for your comments, and that's how we decide the next topics to pick. This discussion today actually started with other discussions. We're very fortunate in our membership to have talented individuals. That being said, I'm going to turn the microphone back over to Dr. Alanna Conder, K4 AAC.
Okay, thank you. Okay, being mindful of time, I think, the slides will be there for anybody who is interested later. I'm going to go just through a few of them, but I'm going to ask Bob to stop briefly for some of them. But there's always going to be a level of equipment that is going to be part of understanding and trying to react to new science. So we even have, at this point, the NFL has position-specific helmets. Next slide. In terms of prevention, you want to have prevention of the catastrophic outcomes. So I think the emergency, understanding the emergency component, which was brought up earlier, the emergency action plans have a critical role. One of them is if you can mandate whether there is supposed to be an athletic trainer, and that's hard to do when you're talking about youth sports and even sports before you get to the level of collegiate. It would be nice if you could just say every school should have a certain number of AEDs. They obviously have identified at this point, it would be great if every facility that did every kind of sport for your grandson when he's a little guy and he's 6 years old and he's just trying to get into it for the first time, all the way up through your middle school and high schooler, would have an AED, an athletic trainer, and CPR trained. It should all be there. And some of those have started to become the norm for schools because of these legislation pieces. And some of them are still hard because they can't mandate you have an AED when they don't provide funds for how expensive they are. And even if a school has them, they have to have them in their academic places to deal with somebody who has an emergency and might need them during school hours. Plus, they have to have them on the field. So the devil is in the details that, all of these are great guidelines, and we need to use them to try to further good management. But you have to realize the details of, if you're saying as the goal is to have every school have an emergency action plan that covers every sport, every season, on every field that you could have athletes, and on non-field activities that are off campus like track and especially cross country. Simultaneously, that might mean you need to have one of those very expensive pieces of machinery, as well as somebody who's CPR trained at every one of those facilities all the time. Just like you can advance it, Bob, in terms of the weather acclimatization and policies, you can certainly train people ahead of time to know what to do for weather, but you can't know ahead of time how you're going to deal with an emergency unless you're trained to understand and recognize it. Commotio cordis is something that's been in the news recently and is one of those illnesses and injuries that's listed by the CSI database. It's not very frequent, but it is an extremely rare medical condition that can happen when a blunt impact to the chest is going to hit an athlete at the specific moment during that narrow window in their cardiac rhythm where it disrupts the heartbeat and you have sudden cardiac arrest. It became more in the public venue in 2023 in January when Damar Hamlin was, an NFL player. It was a televised sport event, and he all of a sudden had sudden cardiac arrest, which people immediately in our field were starting to wonder, was it commotio cordis? And it was. But what you want to be thinking of it is you can't predict when these events are going to happen. You do need to have personnel there trained and knowing how to deal with it. Then next slide, I think we're going to end up skipping, other than to say there are now thunder, lightning, weather-related heat acclimatization. There are guidelines and policies that are in place in lots of different levels to try to help to create infrastructure to mandate how to handle things and increase awareness. But it's still not something that is fully actionable in all venues, especially the ones that are a little bit less, the more community-oriented places where you can get hurt. Next slide. And this slide is just to say quickly that both public schools and private schools, the independent schools, were not required in the legislation, because you can't require something that you can't govern. But now at least in North Carolina and in a lot of the places, the Independent School Association has bought on to all of the same kinds of guidelines and policies for the independent schools. That is not required, so that's going to vary state to state, but more of them are. Next slide. In terms of prevention, in terms of one quick thing, Bob's going to cover this one.
Well, how do you get rules changed? Well, you get Dean Smith involved. This was a letter. One of our players, and Derek Phelps, got a concussion doing a layup play in Boston College in the playoffs in 1994. He was up on the boards. He was clipped, came down, had a serious concussion. The BC coach dissed it. We got kicked out. We lost the game. So I wrote Coach Smith. And Coach Smith immediately realized this is serious. And how do you get rules changed? He went to the basketball rules committee, and that's basically how the concept of flagrant foul was invented. That's enough of that.
Right. There are a lot of slides, and somebody who wants to read this later can go in detail about a lot of things about concussion that are coming from a lot of different, 25, 30 years worth of work that we have been involved in. And I don't really think anybody, especially at 12:05, is probably going to be wanting me to cover all of that. So I just want to say that I will cover a couple of the major slides about concussion, but it does follow in to the category of being more of a quote unquote serious injury that results in a temporary functional disability with hopefully full recovery. It is not catastrophic traumatic brain injury in the sense of the next slide, I think, is going to show. Go on to the next one. Yeah. Go ahead, Bob.
Well, this is sort of my agenda here in terms of all concussions are not equal. And this is from Pat McCrory, leading sports medicine physician, who conceptualized a sports concussion into the minimal characteristic. Those who work with traumatic brain injury know there are 3 classifications via the Glasgow Coma Scale, mild 13 to 15, moderate, and severe. Back in Richmond in physical medicine rehabilitation, we worked with moderate to severe TBI, prolonged illness with usually some functional disability. But the idea now, when you hear a sports concussion, it's serious, but I really would like to tone it down a little bit and look at really what's going on. If a sports concussion, single, uncomplicated, is managed, it should be maybe a 1 to 2 to 3 week partial disability with full recovery. So I think this is a very good graphic from Ricori about conceptualizing where sports concussions fall on the full continuum of traumatic brain injury. It is a traumatic brain injury, but it's not moderate and severe. And a lot of folks are going to this idea of moderate, severe, and the really catastrophic stuff like CTE.
So for those who didn't see the slide, it was just saying that there's sort of a minimal to into the mild range. And then that's for a single uncomplicated sport. We'll talk a little bit just real quickly that, Bob, if you could keep advancing for a second here.
Yeah,
all right.
Tell me.
Different aspects of a concussion. Just most people are thinking you get your head hit and all of a sudden you can't concentrate or you're a little bit dizzy. We now know good data shows that there are a lot of aspects of a concussion and normal things that happen after you sustain a concussion. The fact that there's a lot of different systems involved. There's neurochemical, vestibular, ocular motor, psychological, and neurocognitive. All of those are very real. They are very data-based, but they still are all able to be managed effectively and healed, and so that you don't end up having a persistent or protracted post-concussion recovery process. Next slide. There are lots of symptoms and signs. Knowing the symptoms and signs is the first thing that they always cover in every one of the education. I won't go into them, but to say that they are obviously divided by whether they're physical things like headaches or balance and visual problems, where somebody says that, they're not seeing stars, but things are double vision, that they can't keep their balance, that they're feeling very nauseous because their vestibular system is affected. There's cognitive problems, emotional and sleep problems. All of those are signs and symptoms to be watching for to know whether, in fact, you have a concussion. And next slide, the proposed recovery course in terms of the concussive event, you can see that they call it a window of cerebral vulnerability, is still going to end up going from the concussed event through an acute phase, which is pretty quickly, the post-acute, and then to hopefully a full and complete recovery. Sometimes there is something that is going to go after the post-acute phase where something is going to make it take a little longer. And if we go to the next slide, there are gender differences in who recovers more quickly. Females are at higher risk for sustaining concussions almost across all ages, nearly double. Females are thought to possibly have that because of differences that are like thinner skull thickness, smaller neck muscles, hormonal influences. They're still trying to figure out the whys of all of that. But most of the symptoms that come from a concussion are managed, if managed appropriately, are going to help both genders, and they occur with the symptoms themselves equal frequency. I'm going to talk about headaches for 1 minute with the next slide. There is, just to be aware, post-traumatic headaches. The role of headache in determining who is going to have a persistent post-concussive injury. Persistent does not mean lifetime, and it doesn't mean a severe disability for your lifespan. It means that it's a protracted illness. At this point, they're talking about looking carefully at people up through age 18, and looking at what factors create problems for them. Having a headache pre-injury or migraine history pre-injury makes the chance of having a protracted post-concussion more likely. Having a family member who has migraines, particularly on the maternal side for women, makes them be at higher risk. And post-traumatic headache is designed as a secondary headache that came from and after, presented after and within close proximity, either chronic or acute, to that traumatic head injury, right? So they're the most prevalent type of pain that is occurring after a concussion. And just be aware that there are various different kinds of appropriate and non-appropriate treatments for them. Bob, if you put it on, we're going to keep going past that, keep going. Well, and back to the last one for just 1 minute, but less than a minute. Risk factors that, in addition to being female because you're more likely, there are things that people always want to know. Is there a magic number of concussions? They've stopped having magic numbers. They do certainly say that if you are having probably 3 or more, that you're going to be more likely to be looking in that group to be people who will have prolonged concussions. But we do know that with almost all the professional players, they've had multiple concussions in their lifetime, and they're still not severely incapacitated by any means. They're playing sports, making more money than any of us ever will, probably. So the symptoms, really, they're talking about how many you're going to have, how long they're going to have for the duration. I like to look also at, when people are talking about how much risk, the temporal aspect. So if you have a frequent number of concussions over time, or if your concussion has not actually healed when you have a second concussion. So injuries that occur close in time, you may not have had full recovery from the last prior concussion. Those are the folks that we're looking at having sometimes a more protracted course. And the comorbidities are probably the most important. Migraine, depression, and other mental health disorders, as well as sometimes if you have something that's already cognitively going to increase your load, like ADHD or a learning problem if you're talking about school-based athletes. But particularly the newest studies that are still coming out are saying that they've done factor studies, migraine, depression, and other mental health disorders are the group that is more likely to be as premorbidities and comorbidities to have a protracted need for the appropriate level of tailored treatment quickly. And Bob, the next slide, I think we're going to skip, but go ahead and show me.
Break here, one for ID. This is Whiskey Bravo 5 Delta, Grand Rounds in the Air, Medical Amateur Radio Council Net. Speaking is K4AAC, Dr. Alanna Conder, one of our members here, and Dr. Bob Conder, K4RLC, and currently talking about concussions. And it's important to all amateur radio operators because it's so prominent to be exposed to having a concussion. It happens to those of us just in driving and activities in life, not just the grandchildren in sports. So we hope you find this interesting. We keep referring to slides because we're having a concurrent Zoom presentation. Many of our members aren't 20-meter enabled, HF enabled, being that you move into communities, you're not allowed to attend us. So we do the courtesy of not only doing the Zoom session for our members, but also for the general public, because we take these Zoom sessions, we make them into YouTube videos. So now that you know there's going to be a YouTube video, that gives you the capability here of going onto our Healthcare Hams YouTube channel and seeing those slides and the discussion in a little more detail that's possible on 20 meters. I got a quick question for Dr. Alanna and Bob. On QRZ, on your QRZ pages, is your email address listed on both QRZ pages? Is that correct, Alanna?
Yes.
Okay. And I'm sure Bob's is too. So if you have questions that you don't feel you're getting a chance to ask today, please do ask the questions of them directly through the QRZ email addresses. And we have a number of ways to ask questions. We do pause and ask for questions here on 20 meters. We're also running a NetLogger session, which has an interactive chat feature. And we're also running a Zoom session that has an interactive chat session. So there's lots of opportunity. This is not a presentation or a lecture. This is a forum. This is an interactive forum for all amateur radio operators, not just members of the Medical Amateur Radio Council. So that being said, before we move on the 20-meter side, are there any questions of the presenters? I will pause one to make a list for questions or comments. This is Whiskey Bravo 5 Delta AA 4FL operating in Hawthorne, Florida. Out of the mic is Net Control. Looking for a list of questions. Make your call.
So Charlie 9, Alpha Romeo Papa.
Okay, I've got Kilo Charlie 9 Alpha Romeo Papa, Michaeline, Illinois. Anyone else?
W1HMM.
Okay, W1HMM. Yes, we have Harry. Harry, if it's possible to come in through Zoom for you, your audio might do better. Michaeline, I'm going to let you have the mic first. Realize that I may have to paraphrase because we're not getting a great recording off the 20 meters here today. But go ahead, KC9ARP.
Oh, thank you, Jay. This is a quick question for both doctors. What would your takeaways be since you're presenting a culmination of 35 years worth of your work? What would the takeaways be, just vital information that you would want the audience here on the radio, through Zoom, on NetLogger, to really come away with? What would be most important for you, for us to know? Over.
Were you able to copy that?
Jay, I was able to copy that. And tell her to hang on because there's only about 3 more minutes, and the 2 slides I think away is the takeaways. And I'll read every one of them out. They're really quick. So if she can just hang on for just a minute, that one will be answered.
Okay, that's great.
And they're very short. Bob wrote them.
We'll have an interactive discussion on that. There'll be a forum here, Michaeline. So thank you for being intuitive and knowing where they're headed with that. And this is intended for the general amateur community. And I think Michaeline's comments are very, very vital and important to target. We do want to have takeaways here for everybody that's on 20 meters. So to surmise, and then you can follow up additional information that you might want. So Michaeline, KC9ARP, this is Whiskey Bravo 5 Delta. Fantastic comments. Do appreciate that. We also had some comments or questions from the W1HMM. Harry, were you able to come in through Zoom video? Go ahead.
Yeah, Jay, I can come in. I can wait till the end. My comment and question are probably more appropriate at that point.
Well, go ahead now and we'll get a preview.
Okay. I was curious as to the efforts that are being made for concussion awareness, and are they stressing the importance of having an athletic trainer on site rather than just having EMS on standby? I ask that because EMS is not trained in general. There may be systems across the country that are, but they are definitely the exception more than the rule. EMS is not trained on evaluation of concussions and making that play, no play decision. Yet I know that ambulances that are standing by at sporting events are often asked to make that decision. And I think it's a risk for both the athlete and the providers that are on scene. And I think having an athletic trainer is definitely a better idea. Or having an athletic trainer in addition to EMS is probably the best idea. Are there any moves to make that recommendation in these efforts?
Harry, before we answer that question, could you tell us a little bit more about your background and where the question's coming from a professional standpoint?
Sure, thanks. My background is as a paramedic. I've been working on ambulances since 1980. I have done, I can't even count the number of football games, hockey games, basketball games that I have parked my ambulance at, and then been asked to evaluate somebody who took a very significant hit and make the decision whether they're going back into the game or not. And I have had some coaches and players get very upset with me when my answer is always the same. Well, I don't know for sure. I think you should probably go get evaluated.
Yeah, thank you, W1HML. I'm going to turn the microphone over for not only a response to that, but weaving it into the general, completion of the topic here today. I'm going to turn the mic over to K4AAC, Dr. Alanna Conder. Go ahead, Alanna.
Okay. And Bob too. I mean, first of all, Harry, great question. It's complicated because the access to resources isn't equally distributed. So, I mean, it's really crazy, but here's this going back to the catastrophic sports people who are talking about, they're looking at national data and what needs to be done. And the whole point is to create actionable requirements, guidelines, and recommendations, and then to get those, disseminated so that, a guideline that's in a closet is no help to anybody, to get them to the point where they can be used nationally and use their status as a well-esteemed organization that's basing this on a lot of data over a lot of time. But clearly having an athletic trainer at any sporting event would be ideal, and it would be the best. And it's becoming more and more the case that places are finding the funding and creating the awareness that the athletic trainer really does need to be there and available. What they are doing in places where that isn't as feasible because of financial or infrastructure limitations, I think, is to make sure that there are athletic trainers who sometimes can't be on site at every sporting event, but athletic trainers, as well as the CDC, have really good training guidelines and requirements for those the guidelines have requirements that you have watched and then practiced and shown that you have awareness of what you should be doing in the event of various types of injuries, as well as how you're making return to play versus at this point, most of the venues that are able to say there's an immediate polling of the player, make it less hard for people like you who are being asked to decide. If you have any concussion sign or symptom that you should be polled, caution is better, and that you don't return to play. But having athletic trainers who are there and who are also creating videos and creating training for their athletic coaches who are on site, at least there's some person who's the one in charge who can help to make some of those decisions interactively with the EMT person who would be there potentially as well. Bob, did you have something else you wanted?
No, I think you did that really well. I guess, again, a lot of the certified athletic trainer will have basic training similar to an EMT with CPR, AED, life-saving training. There's this whole chain that goes up from the certified trainer to the EMT, the transport to trauma. We've got level 1 trauma centers here. So it's a really good point. And the other thing, we don't have time, is there's sideline assessment, which Alanna and I have done in terms of using tools like the SCAT, Sideline Concussion Assessment Tool, where you pull a player out on the sidelines and assess them after a hit to see if they have signs or symptoms of a concussion, and then keep them from going back into the game. So you shouldn't be required to do that. There's very specific training tools that someone should go through. You see it now in the pros in college. They've got the tent, take the person in the tent in a way. And it's a lot of fun working on the sidelines of Friday night football. It's pretty intense. And you tell a player they can't go back in, you're really sort of making somebody unhappy. But there's very specific training, and I would turf, like you're saying, because that's not part of your training.
The other thing I would add into that is that those sideline assessments, all of the training of not only their use, but also having coaches be aware of why you need to respect that there might be a sideline person available to do that and why you let them, because you don't want your players filled. All of that, there's more and more education to various school-based athletics for that built in, especially here in North Carolina because of the legislation, but in most states, they're getting more of that. The CDC, the Heads Up program, if you go on that website, and you might want to, they have everything broken down for free. You can download as many as you want to of different things that are signs and symptoms or checklists or what are, we've done them, given them out freely to coaches to get them to be on board so that they're not fighting a player not being pulled, as well as to the other staff who are there, who are medical, but who, or who are, available to help make assessments, and do some of these. All of that information, all of the materials are free. You just download them. So it's a good resource for anyone to be using who wants to say, hey, look, I did this little quick checklist, and they already meet the criteria. You do need to, when in doubt, sit them out. If you do end up having a sport concussion, there's lots of appropriate treatment that is available. And it can be looking at all those different phases of a concussion where the recovery may be stalled for a little bit in terms of any kind of, training for the vestibular system or the ocular motor system. We have more of an idea of what are all of the different levels of what are appropriate targeted intervention. Active rehabilitation, just to give you one sentence about that, it used to be that nobody wanted to pull anybody from a sport when there was a concussion because you'd ruin the game. Then all of a sudden there was this idea you pull them out and you put them in a dark room for ages. The data now says you have to do active physical rehabilitation much earlier in the acute post-concussion process, and that you do it to the point where they're getting exercise at a graduated level that is sub-threshold for triggering return of symptoms. But you do active rehabilitation much earlier, and that is probably something that in the last 5 years of concussion management has been one of the biggest changes. And then the other piece is to, even in a study that has just come out recently by some of our colleagues, to look at the pre-existing problems with headache or with depression and anxiety making a person prone. Those are non-medical, but more, or they're non-concussion specific. If you address this quickly, targeted correctly, and use evidence-based treatment for them, that the prognosis is much better. I do want to, I don't know that we have any time. We could do a whole talk on heart rate variability. We won't do any of that. But if we advance to the slide that says,
well, let me just say here, the idea is evidence-based training, not off-label. There's all kinds of junk out there on the internet. And in this study that was done at Dartmouth Medical Center, 90% of the young adults with prolonged a month or greater post-concussive symptoms did not have evidence-based training. They had sort of off-level training. This one, this is crazy. We wrote this article. Actually, Jack Ginsburg at the VA was doing a series on post-traumatic stress disorder and said, hey, Bob, is there anything about concussions and heart rate variability, which is a way of training people to change the time constant between their R waves? And I said, I don't know, I'll look into it. So we wrote this article, and it's amazing me. As of this week, we have over 45,000 hits and downloads all over the world. And what's really interesting, if you go over here, to the left of Mongolia, you see 19. If you go on the website, you can click. You used to be able to go down street level, but if you click on this, you go to a place called Novorossiysk in Siberia, where there are 15 hits on this. That is a loosely regarded a Russian medical school research institute where they may not have used informed consent with their research. And actually, this science may have been developed there back in the 60s for cosmonauts. Anyway, it's a way of treating concussion using the brain, the neurocardiac axis. Here's your takeaway. Sorry.
Here's the takeaways. Okay, so takeaways from this talk. Injuries obviously occur in everyday life, not just in sports. Injuries occur in sports. Catastrophic injuries can be prevented. Prevention is driven by good data collection, which impacts the training and the on-the-field play. So again, it has to be good data. There is lots of people who have theories, but good data collection and very rigorous data collection can impact what kinds of, and then the data collection extends not only to the ideas, but when you do training, then to look at what kind of training helped. And when you create specific types of treatment, data collection on whether those treatments are effective and appropriate. Concussions receive most of the press, but cardiac injuries and illnesses occur equally often. So be thinking heart is just as important as brain in terms of what's likely to have a potential for a catastrophic injury during play. And the research into equipment, safe play, training, coaching, all of it needs to be continuous because there's always a feedback loop so that you take the newest data collection and then you apply it to the newest guidelines. The guidelines for concussion in sport were reviewed in 2022. A whole field, bunch of our colleagues are involved in doing this every usually
4
about 6 years. The last one took 6, but I guess
well, they skipped because of COVID.
Yeah. So every 4 years, all of these big heavyweights who are very much multidisciplinary heavyweights have this concussion consensus statement that helps to guide how all of this is done internationally, not just nationally. And the new one in 2022 used new data to talk more specifically about the prolonged concussion factors and what puts you at risk. But each time it helps to decide, what are better guidelines so that there's a standard metric being used to do some of the diagnosis and some of the research in all across this country and in other countries, so as to better manage concussions. And concussions are just one type of catastrophic sports injury. And although it gets more press, and I certainly have spent a lot of my time treating that, it's really one of the more manageable and more likely to not lead to a devastating outcome injuries related to sport. So keeping it in perspective. That's, I would say, takeaways. Hopefully that answered some.
Thank you, Alanna. K4AAC, this is AA4F Alpha Mike Net Control, Whiskey Bravo Phelps Delta, the Medical Amateur Radio Council. Those are great takeaways. I hope that was what you were looking for, KC9ARP, Michaeline, in part. I have a little follow-up on the takeaway because this is going to be formulated for the Ether publication. Our public, I can see right now it's going to take 3 or 4 pages of the Ether. And we'll have the opportunity, because our Ether publication is available to the public, has hypertext. So it's written on all levels for health professionals, for the general amateur community, for non-hams as well. It gives everybody the opportunity. So what we say whenever we present our information to our members, we make it available to them to look, listen, and read. We put it out as a YouTube video. That's the look, the listen. We have our web stream running, and then we also have, if we can mute there, Bob, just mute for a minute. So we also have our ability to read through the hypertext. So that that's the format that we take as a group. But on the look and listen, I think as you're looking around and you have grandchildren, I think another takeaway might be to be cognizant of what's happening at the local level. You may live in a rural community that doesn't have the funding for everything that's being mandated or suggested, but yet you want your grandchild to be protected. So you can be an advocate. There's no reason why you shouldn't be aware and ask questions as an amateur radio operator, as a member of Marco, as a member of the general community that might be seeing the YouTube video. So please do consider that. Another comment that we also talk about consistently on our net and the Ether be careful of the online information, as Dr. Alanna K4AAC mentioned. Just because it's on the internet, and Bob mentioned the same thing, K4RLC, it doesn't make it legitimate information. Anybody can say whatever they want. Don't take everything by just one resource. Try to find reputable resources and cross-resource and find relevant research as well. If you're not a health professional and you have a hard time reading what the CDC puts out or the National Institutes of Health, I mean, we're going to cover the article here as well in our Ether publication. We try to be the interface here that assists the general amateur community and the general public in interpreting what we see, those of us that are in the professions. And I'm certainly not, as a dentist, I don't run into anything in this topic. But we do appreciate you being here both today and offering your expertise for 20 meter, for our net. And I'm going to open up the microphone on 20 meters now for anyone that would like some follow-up questions against the Grand Rounds of the Air Net, Medical Amateur Radio Council, open to all amateurs looking for questions. I'll make a list here, make your call. Okay, we have one comment from WB9EDP. Anyone else that would like to speak? Okay, Harry, go ahead.
This is primarily addressed to Harry, which is not me, but the other Harry there. And a big shout out to all of the EMTs and paramedics. There is a major difference between paramedics and EMTs. Just I'm in Decatur, Illinois, but dealt with Chicago, and the paramedics I had the pleasure of training were superlative in every way and shape and form. But the one thing I will bring forth is no one, the trainer spent some false hope, and they're not carrying the liability. You can mind that liability is very important in NATO, at least the United States. So if there was the slightest doubt, any paramedics might be out and we go through protocol. I still believe in the 6 weeks, just vigilance of keeping an eye out for someone. I've seen people present post-bleeds, repeat leads, as far out as 7 weeks with presentation of a concussion. So from the paramedic standpoint, the basic assessment is basically looking at what happened, and if there's any chance of head trauma, package them, put them in a box, bring them to us. I don't want a trainer making that evaluation. I don't want anything. That's going to kill people, period. End of story. But my heart goes out to every paramedic on the field that I've dealt with, and I'm sure Harry is the other area. Superlative big, and I'm confident that they do a fantastic job there. And that assessment, I wouldn't give a hoot to anybody unless I'm talking to a neurologist, and I still want to look at a picture of the head. I want to look at a picture of the spine. I need to have the paramedics bring them in, package them, so I could clear that meeting. Make an assessment if necessary by calling a neurosurgeon. I've ended up putting valves in people at 1 a.m. Because of a misread. Can
I, Jay, is somebody?
Every paramedic I've been in contact with, they've made me proud of a great paramedic as well. That's very important, Jay. More important than numbers and cases. That's all politics and epidemiology, not medicine. WB5B, WB9 Echo Delta Papa.
Okay, WB9EDP, thank you for your comments. Harry, K4RLC, Bob, did you have some follow-up comments you'd like to make?
Well, I think Harry needs to get educated in this area. There are indications for neuroimaging. There's a whole section of sports medicine that looks at this and looks at what's athletic trainers capable of doing, EMTs and et cetera, chain of command. So I would encourage Harry to go back and go to workshops and certified workshops and to get training in the area to see what's going on with hundreds of thousands of schools throughout the United States. It's very safe, and what we're talking about are return to play decisions versus a higher level of injury on the field. But there's a lot of training out there, and I would encourage Harry or anybody to go out, starting with the CDC stuff. I think everybody should go to your local Red Cross or American Heart Association and get trained in CPR to AED, infant, child, and adult, and work up from that. But this is science that's out there, and I think you need to stay up to date with the data. We work in the field and do this for a living, so we're on the cutting edge of this.
Okay, thank you, Bob. And no disrespect to Harry or for any of us here. You know, many of us, the Medical Amateur Radio Council, have been in our careers and our professions for years, and some of us are retired, and perhaps we're not aware of the most recent status, and that's no disrespect to any of our members that have comments, but that's true of myself in dentistry. You're having to constantly re-educate yourself, and this is happening. As Dr. Alanna mentioned, just a public awareness raised from 2023 when Hamlin was injured on national TV and they actually stopped an NFL game. I mean, think about the outcome from an event such as that and what happens on the legislative side and the rules side. And that's just from 2023. So, for those of us that worked in the field in 2015 or 2010, a lot has changed. So we'll have the opportunity for a lot of follow-up, questions. You can always email them directly using the QRZ. But we're well over our normal allotted net time. I'd like to thank very much Drs. Alanna and Dr. Bob Conder, K4AAC for Dr. Alanna, K4RLC for Dr. Bob. They enjoy amateur radio, they enjoy their careers, and they enjoy the Medical Amateur Radio Council, and they share their passion for all of the above with our members and the general public here on the net, with the general amateur community on the net. We hope if you're listening here in 20 meters and you did not ask a question, that you were still an active listener and benefiting from the use of the 20-meter airwaves in this way that we do every week in discussions. Usually the topics are a little less intense. Here it's just such an important topic. I mean, think about all the family members that could be affected and extrapolate the sports injuries to the non-sports industries that you're at risk for. Very important information to follow up on. Please look for the articles in the ether. And thank you again, Bob and Alanna. That being said, I'm going to bring the net to the week to a close. I'm going to go ahead and stop the Zoom recording at this point. Thank you for all the general public that's listening, but I'm not stopping the session for those of you that are on Zoom.